Okay, so good afternoon. I would actually discuss for today, I would focus on what is eosinophilia and a little bit of history of eosinophilia as well, causes of eosinophilia, and of course, how to approach eosinophilia and when to refer to your friendly hematologist. Okay, then we will actually discuss investigations of eosinophilia, and at the end, summarize the talk. So eosinophilia is defined as an elevation of the eosinophil counts above levels observed in healthy subjects, okay, usually taken as above zero point 0.5 times 10 to the power of 9 per liter. So under light microscopy, eosinophils are rounded cells of about 15 microns in diameter, larger than other blood cells like erythrocytes, lymphocytes, and basophil. So eosinophils actually they show a nucleus, okay, with two lobes and a thin nuclear bridge in between, okay, connecting both lobes. The cytoplasm contains many granules known as specific granules, which are actually stained in orange red with acidic dyes like eosin. The degree of eosinophil is subdivided into mild, okay, with an absolute eosinophil counts of zero point 0.5 to 1, and moderate if it's actually the absolute eosinophil counts is 1 to 5, and severe if actually it's greater than 5 times 10 to the power of 9 per liter. The history of eosinophils traced back when Julius Vogel described it as a first time these numerous granules cells which are most part round but sometimes elongated or even angular. It is difficult to distinguish whether these granules, okay, are on the surface or in the interior of the cell. This was published in his book, The Human Body, in 1847. Then in 1879, Paul Ehrlich published his technique of staining the blood film in his method for differential blood cell counting using a coal tar dyes and mentioned that the eosinophil for the first time. This was published in the 1900s in his colored plate from the history of the blood. Recognition of hematological malignancies associated with eosinophilia started in 1968, wherein Hardy and Anderson coined the term hypereosinophilic syndrome. So through the years, it continues to evolve as more gene rearrangement are discovered. So recently, in this year, okay, the WHO published its fifth edition of the WHO classification of lymphoid tumors, myeloid and histiocytic dendritic neoplasm, wherein more genetic abnormalities are added to the list. Okay, as a quick summary, okay, causes of eosinophilia is divided into secondary and primary. Okay, as a clinician, it is important for us to identify whether eosinophilia is a secondary cause or a primary cause. There are a lot of secondary causes. I'll not tackle most of them, but these are the causes of your secondary eosinophilia. First, allergic reactions such as asthma or atopic dermatitis or eczema. Some non-allergic dermatological disorders can cause your eosinophilia. Drugs, including antibiotics or anticonvulsants, okay, which I will show the slides later, can cause also eosinophilia as well. Infectious diseases, especially parasitic infection or fungal infections, okay, and other systems such as your GI disorders, okay, rheumatological disorders as well. Respiratory diseases can actually cause your eosinophilia. Not common, but also atheroembolic disease can also cause eosinophilia. In terms of parasitism, okay, strongyloides, hookworm, and filariasis can also present with eosinophilia. Both strongyloides and filariasis can present with eosinophilia as the only main feature as well. Okay. For these parasitism, okay, fresh stool microscopy can be key to investigation. For filariasis, may need blood smears as indicated here in the table. Other not so common parasitism like your toxocariasis trichinosis, or schistomiasis can also cause eosinophilia, but they do tend to have more symptoms compared to the other three mentioned before. However, there are some reports that schistomiasis may present with eosinophilia as the or the only manifestation. These are the lists of drugs that can cause eosinophilia with their manifestation. Example of which are your very familiar DRESS syndrome, wherein it's commonly associated with your allopurinol, carbamazepine, also sulfasalazine drugs. So you can actually see here that sometimes NSAID also can actually be associated with eosinophilia with pulmonary infiltrates or gastroenterocolitis. Just to highlight that there are some papers to support, okay, that strongyloides can present with eosinophilia as one of its features. So this article regarding South Asian migrants in the UK, it was found out that their positive strongyloides serology was found in 33.6% in eosinophilia cohort against 12.5 in the phlebotomy control. There is also one published case report in Singapore as well. Patient presented with cellulitis, eosinophilic cellulitis, and secondary to occult strongyloides, wherein the patient's eosinophil ranges from zero point 0.9 to 171. Other secondary causes of your eosinophilia can be neoplasm, solid tumors also as well, or maybe can be associated with lymphomas and acute lymphoblastic leukemia. If we are talking more of primary causes, okay, these are the list of primary eosinophilia, and most of them are related to hematological malignancy. So, if the clinician do believe that the cause of your eosinophilia is more malignancy, then we can refer to your friendly hematologist. But I will actually discuss on the next slides how to guide us with the approach of eosinophilia and when to refer. Okay, so the first step is actually your history and physical examination, wherein your history should elicit symptoms that may reflect organ involvement by eosinophils, and that is including a complete review of systems. Okay, the history should seek to identify conditions that may cause actually your eosinophilia, including asthma, atopy, rheumatologic conditions, infections, malignancy, or potential exposures and family history as well. As listed here, you can actually see that you have to ask them if they have constitutional symptoms like fever, night sweats, or unintentional weight loss or fatigue, or cutaneous manifestations like rash, pruritus, eczema, or ulcers as well. They may have also your cardiac symptoms, dyspnea, chest pain, palpitations. They are symptoms of heart failure, respiratory, also as wheezing, cough, or chest congestion, or maybe they are having diarrhea as a gastrointestinal manifestation, vomiting, food intolerance, changes in stool habit as well, or manifestation in the nervous system like transient ischemic attack or cerebrovascular accident, or changes in behavior, changes in vision, numbness, weakness, or pain. And of course, if they have symptoms attributable to lymphadenopathy or hepatosplenomegaly, like abdominal chest discomfort, early satiety as well. This table actually will guide us on what disease entity are we dealing with. So, if for example you have actually mild eosinophilia, wherein your eosinophil counts is um, zero point 0.5 to 1, or if for example 500 to 1 with your eosinophils, with the level of your eosinophils, then the differential diagnosis would be like allergic diseases, atopy, asthma, or drugs, or can be allergy or bacterial and viral infection. If your degree of eosinophilia is moderate, okay, you might be actually dealing with parasitic infection, okay, or examples like your Church-Strauss syndrome, cancer, or Sézary syndrome. Or if you have actually severe eosinophilia, then most likely you might be dealing with hematological malignancies like your eosinophilic disorders and cancers. So this is actually an algorithm, okay, on how we deal with eosinophilia. Okay, so of course we will have to evaluate for secondary causes and also approach with history and physical examination. So your history is directed to um, disease entities such as allergic diseases, rashes, medications, or you have to ask their dietary habits also as well. Of course, travel history and connective tissue diseases or malignancies. So usually we do a base laboratory test, which I call it a tier one investigation or level one investigation, that I would usually send a full blood count with, of course, differential count or absolute eosinophilic count with peripheral blood film. I would also do a liver function test. Also, I would also do a creatinine just to check whether the kidneys are okay. If there is a suspected cause of parasitism, or sometimes I usually send it, like I would send a stool ova and parasite. If there are tests to actually see where there is a parasite using serologic test, then I would also set especially for strongyloides as well. ESR, CRP, vitamin B12 and folate, LDH, and chest X-ray. But if you are suspecting that the patient have a um, autoimmune causes or rheumatological disorder, then I would send an ANA, dsDNA, or Hancock. I'm suspecting that this patient would have actually a GI cause, then perhaps I would send an amylase lipase. And or if this patient has also suspected allergic causes, okay, and then I would send an. So if your eosinophilia counts or absolute eosinophilic counts is mild and or secondary eosinophilia, most of the time I would actually treat them, give them empirical parasitic treatment, which I will discuss later. But also you have to treat the underlying disease, okay? And ensure regular follow-up. Ensure that these patients, after the follow-up, they would have the eosinophilia normalized or their eosinophilic counts would actually return to the norm. However, if your patients have moderate eosinophilia without symptoms, okay, I would still actually give empirical parasitic treatment, but I would follow up them in 1 month's time. And then in 1 month's time, if for example the eosinophilia go down to mild, okay, that is less than 1.5, then I would ensure a follow up again and ensure that the eosinophilia normalized. If it doesn't normalize, okay, I would actually do tier 2 investigation. Tier 2 investigation or level 2 investigation means say you have to organ involvement of the eosinophilia. If you are suspecting a lung cause, usually we do a pulmonary function test. If there is an heart causes or heart, we will actually do investigations like your eye, ECG, or echocardiogram. If you have a GI cause, sometimes a CT abdomen, ultrasound, or refer to your friendly gastroenterologist for scopes. And then if tissue biopsy is indicated, then do such. If these are two investigations are too normal, they don't have symptoms, okay, then you have to assess the assessment of eosinophils and organ involvement at a regular interval. However, if your patient have moderate eosinophilia with symptoms, usually these patients are actually admitted. You have to urgently evaluate their symptoms. They might have a heart or CNS involvement, or if they have thromboembolic events, okay. But if they don't have, okay, then still proceed with prior to investigation. But if the patient do have symptoms, then you have to refer to us. We will actually do prior to investigations, molecular markers such as JAK2, BCR8, or look for systemic mastocytosis tryptase, or we will do primary investigation. Okay? But if they But if the patient do have a moderate severe eosinophilia, which suggesting a myeloid malignancy, okay, then of course refer also to us, and then we will actually do tier 2 investigations. If it is not done, we have to look for any organ involvement of eosinophilia and also do our tier 3 investigation. Then we will treat as indicated depending on what is the underlying hematological malignancy. We will treat it with corticosteroids or empirical parasitic treatment, like I mentioned before. Okay, these are actually mostly indicated for mild to moderate eosinophilia, wherein we will give ivermectin, which is actually 200 microgram per kilogram single dose, and albendazole 500 milligram once dose. Okay, um, usually would not give to eosinophilia that is severe. Okay, and then I would follow up this patient 1 month to 6 weeks to actually see if the eosinophil do actually rise. As I said, investigation for eosinophilia, tier 1 investigation. I would actually send all cases of eosinophilia, your full blood count with differential counts, especially there is an absolute eosinophilic counts, your peripheral blood film, liver function test, okay, creatinine, then stool, stool over and parasite. If you have a serologic test for parasite like strongyloides serology, then ESR, CR, vitamin B12, and LDH, and chest X-ray as well. So if you are suspecting connective tissue disorder or rheumatological disorder, then you can send an ENA, dsDNA, or ANCA as well. If you are suspecting a allergic etiology, you can send if you have. Okay. And then suspected GI cause. If you have a suspected GI cause, then amylase and lactase. Tier 2 investigation, these are evaluation of organ involvement. Like I mentioned before, other function test if suspected lung cause, suspected cardiac cause, then I would send troponin ECG. Then an echocardiogram, sometimes I would to our friendly cardiologist to rule out organ involvement in the heart, a CT abdomen ultrasound, are thinking that are um, GI related causes. Or if you have lymphadenopathy, then tissue biopsy also if indicated. Sometimes if you have really very widespread rashes also would actually would refer to dermatology and tissue biopsy or skin biopsy. If you have a suspected GI cause, then most likely refer to your friendly gastroenterologist to your upper GI endoscopy, small bowel endoscopy, and or colonoscopy or sigmoidoscopy, depending on the patient. Tier 3 investigations are mainly hematological workup that we would actually do. Okay, just would like to mention that tier 3 investigation are mainly molecular markers like your JAK2, D617, or BCR812. Okay, or it's like your Philippine 1, PBGFRA, which can be sent by FISH or RT-PCR. If we are suspecting systemic mastocytosis, we can actually present with eosinophilia as well, then tryptase. We will send tryptase as well. And also we will do our examination, we will actually send for aspirate, flow cytometry, and also fine biopsy, and also cytogenetics. And if it's really clinically indicated, also um, if it's available, an GS panel as well. So in summary, okay, there are many algorithms that have been developed to analyze causes and associations of patients with eosinophilia. I specifically choose that slide or algorithm as well because it's easy to understand and you can actually prepare one investigation in your clinics as well. Uh, the first step is to review your history. Okay, very important. Review history. So do your physical examination that would reflect organ and eosinophils and identify the cause of your eosinophil. For your mild and moderate or secondary eosinophilia, without symptoms, okay? Specify without symptoms, treat the underlying cause, but ensure follow up. Make sure that the eosinophil normalize in due time. You can actually give prophylactic parasitic treatment. Okay? You can offer this prophylactic treatment to your patients as well. All cases of eosinophilia should have a basic lab test, which I said first year. If required to go further on the second or third year of investigations, then it